All right. Thank you all again for joining us today for Aspire Institute's faculty seminar. I'm honored to introduce today's speaker, Dr. Caroline Buckee. Dr. Caroline Buckee is a professor of epidemiology and associate director of the Center for Communicable Disease Dynamics at Harvard T.H. Chan School of Public Health. She is the co-founder of Crisis Ready, a platform enabling rapid data-driven response to public health emergencies. Her work is focused on understanding the mechanisms driving the spread of infectious diseases that impact the most vulnerable populations worldwide, particularly malaria. Before coming to Harvard, Dr. Buckee completed a D.Phil at the University of Oxford and Omidyar and Wellcome Trust fellowships at the Santa Fe Institute and the Kenya Medical Research Institute, respectively, where she analyzed malaria, parasite evolution, and epidemiology. Dr. Buckee's group uses a range of mathematical models, experimental and genomic data, and big data from mobile phones and satellites to understand how human pathogens spread and may be controlled. Her group works closely with the public health practitioners to translate new data streams and analytical approaches into interventions at the local level. Thank you, everyone, and I'd now like to introduce Dr. Caroline Buckee.
Hello, everybody. Good morning, good afternoon, good evening, depending on where you are. It's a pleasure to join you today. I was here last year as well, and it's just so great to see all the countries that you represent and where you're all from, and I really appreciate your time. I'm going to share my screen. Can you see that? I think so. So I see there are a number of questions already relating to the previous seminar. Maybe, I don't know how you want to handle that, but
we'll handle those questions. We'll leave the questions that are related to the session in the Q&A, and we'll pull from those specific ones. We'll answer any unrelated questions.
Okay, great. All right, so today I'm going to talk about public health emergencies. And, you know, I'm coming at this from a background in infectious disease epidemiology, and I started out studying malaria. I was actually a zoologist by training as an undergrad. And then I got into bioinformatics and genomics, and then subsequently more into applied public health. And as my career has progressed, I've realized how overlapping some of the threats are, and fundamentally the fact that many of these public health emergencies coalesce and congregate in the same populations who are at risk. And so today I'm going to talk about that, some of the ways that we can use new data streams to help surveillance and resource allocation in the context of public health emergencies, as well as some of the challenges that I think you will all be kind of familiar with, but in this context, I'll talk about it in with a technical view. First, I want to start by acknowledging the members of my group, past and present. The work that you'll see today is in large part due to their hard work as graduate students or postdocs in my group. And so I just want to acknowledge that upfront. None of the work that we do could be accomplished without graduate students, postdocs, our partners on the ground, local epidemiologists, ministries of health, disaster response agencies, and so on. And oftentimes people like me get to give the presentation, but in fact, science is increasingly a group effort, and we need many people who should be taking credit for a lot of this work as well. Okay, so I want to talk about some general problems that we're facing as a global population for our world and in the context of public health emergencies. First of all of you will have seen a graph like this. We've had exponential population growth post-industrial revolution in the West, and in many parts of the world, we now have huge numbers of people that we did not have to deal with about 200, 300, 400 years ago. Now, what that means is that the sheer numbers in terms of resources required has changed a lot and continues to grow. So population is growing rapidly. We have a non-uniform distribution of people with megacities emerging as a major feature of our 21st century landscape. So Asia in particular is very densely populated, and many people are living in South and East Asia, for example. The other thing that's happened just recently is that we are now an urban world. So in 2014, I think it was, we transitioned to more people around the globe living in urban places compared to rural places. And you can see here percent urban in these bar charts by region, with a projection out to 2030. And you can see by 2030, it's projected that certainly over half on every continent, but in certain places, it's going to be the vast majority of people will be urban rather than rural. And that's another thing to keep in mind when we're talking about disasters and how we're going to be more resilient moving forward. We have to factor in cities and megacities. So this is an aerial view of Manila. The population density creates challenges for public health, and it also creates an opportunity for pathogens to spread very quickly. It's like, imagine we're making a bonfire where we're putting all of the sticks together at close proximity. Fire can spread very quickly compared to if it's very spread out. And so we can think about epidemics in the same way as being able to transmit very fast in densely populated areas. The other thing that's happening is that we have this demographic shift in some countries that will probably continue globally, although not everywhere has population pyramids like this. So if you haven't seen a population pyramid before, what we're looking at is the distribution of ages in men and women around the world. And this is from different time points. So the pink is women, the blue is men, which is very sexist, but there we go. This is an old figure. And then you see the age groups, with the bottom bars being the youngest age group all the way up to the 75-year-olds here at the top. And so in many populations, what we're seeing is we've gone from a pyramidal age structure. So here's where most people are young, children and teens, at the bottom of the pyramid here. And then as that population ages, we end up with a population pyramid like this one on the right, where we have a lot of older people. And less younger people. And so the distribution of age groups in a population, and especially in our countries with many aging people, they have particular kinds of vulnerabilities when it comes to public health emergencies. And again, it's important to keep some of those demographic features in mind when we're talking about responding and being resilient. Now, the other thing that's really changed, and this is going to be the focus of my talk because it's what my group has worked on for many years now, is the fact that we've also become incredibly mobile as a species. So these graphs are an interesting historian plotted the lifetime distance traveled by his great-grandfather, his grandfather, his father, and himself. So you could see this is in England, his great-grandfather barely traveled in the tens of kilometers. His grandfather maybe traveled to some counties. His father went across Europe, and now modern travel connects all of us globally, which of course you're very familiar with. So we have enormous volumes of people that connect us around the world. And again, from an infectious disease standpoint, this means that pathogens are now a global problem. They can no longer be thought of as a localized issue, but rather they affect all of us. And as we've seen with COVID-19, we can have a pandemic which essentially shuts down large parts of the world for some time and causes huge amounts of morbidity and mortality, as well as economic problems. And so, you know, COVID is, of course, top of mind, but this has been going on for some time. This map just shows the spread of H1N1 flu out of Mexico in 2009, and it very rapidly spread. You can see here's the timescale. In a few months, it had spread all over the world thanks to international travel. So we are a globally connected world. We're an increasingly old world, and we're an increasingly urban and densely populated world. And that's quite a new feature of our societies. And it's something that really is at the heart of how we think about responding to the threats that face us. So I've talked about international travel. On a more local level, we've seen an increase in migration on different scales as well. So cross-border migration, this heat map is supposed to represent, for example, the prevalence of an infectious disease. So say you have a disease which occurs on the border of a country. you're going to get infections spreading from across the border, especially if there's illegal travel and across porous borders, which happens in many parts of the world. And then, of course, the international migration that we just talked about can bring in pathogens from overseas. We also have a lot of internal migration, and something that I'm interested in is in labor migration. I work a lot with mining populations that move cyclically, looking for work opportunities, often men of working age. And what that internal migration does is it basically mixes people up within a country, and it means that where you have transmission of a pathogen, labor migrants and other internal reasons for migration can spread that pathogen to other parts of the country quite rapidly. And we'll see in a bit that that can happen, for example, in the context of travel for holidays. At Christmas, we often get the spread of flu strains. In South Asia during Eid, in Bangladesh, we might see the spread of pathogens as well. And then finally, and this is where epidemics and natural disasters overlap, if we have natural disasters, and in the context of climate change, this is becoming an increasing concern, we can see mass displacement of populations away from, for example, floods in the context of Pakistan recently. Bangladesh has frequent cyclones where people need to move away. And here in the US, we have wildfires and things like that, hurricanes. So there we get large population movements as well. And I want to point out that although I'm an infectious disease epidemiologist by training, public health emergencies tend to be entangled with each other. So this flow chart describes how natural hazards or hurricanes, things like that, and armed conflict can lead to infectious disease outbreaks. And in fact, many of the issues that vulnerable populations face are the same, whether it's a large epidemic, whether it's endemic malaria, whether it's conflict-prone regions, or whether it's somewhere that's facing cyclones or hurricanes. And what happens is, and you can see, let's just follow the flow for natural hazards, following infrastructure damage or flooding or something like this, people are displaced. So then immediately they have wash needs, that's water and sanitation. They have housing needs, so we need to respond to people that need shelter. Often that leads to overcrowding, or for example, in refugee settings, maybe unsafe drinking water, not great sanitation, and those set up the conditions required for an epidemic to take off. So you'll see subsequent to hurricanes and floods, you'll see outbreaks of disease. So for example, after the floods in Pakistan, we saw a resurgence of malaria and a big dengue outbreak. And that's a common situation. We often get leptospirosis outbreaks in the wake of flooding, and so on. Similarly, with armed conflict, what ends up happening is that people have to flee, there's damage to infrastructure, there's often destruction of healthcare facilities, and people can't get access to basic healthcare. And there may also be damage that causes some of these hygiene and sanitation issues, as well as crowding. So again, all of these threats that come with some of the 21st century realities are intertwined. And infectious disease outbreaks and epidemics are related to the problems of natural disasters and armed conflict. And some of the things that we need to do to respond and prepare for them are also overlapping. And so really, I think that we need to shift away from silos where we think I'm an epidemiologist that does this kind of disease, and instead start to think about vulnerability as a community to the suite of public health threats that are facing us. Right. Okay. And so this is obviously a map of Syria. On the left, we have a heat map that shows where people are living. So it's a population distribution density map. So the blue dots, the dark blue dots, are where you have high density. That's where there are cities or people living. And then yellow is where there's very low density and not many people. And so in Syria, like in other places, people live along rivers. You can see the cities here and these dense blue dots. And then here on the right is a heat map showing, this is just a snapshot from a cholera outbreak at the end of 2022 in Syria. And you can see that even though there are people everywhere, and the cholera generally occurs where people are, of course, because infectious diseases will follow people and was all our infrastructure as well, it hits different communities differently. And so we have heterogeneous distribution of threats, heterogeneous distribution of what we need to do to respond. And it's this spatial distribution of risk, the spatial distribution that underlies it. Often this is socioeconomic status. It's to do with historic differences in populations. It's to do with access to healthcare. And sometimes it's to do with your biology and your environment. So for example, places where mosquitoes can breed if it's malaria, or places where they can't breed, and so on. So understanding how different aspects of infectious disease impact different populations is one of the ways that we need to start responding to these threats. Of course, globally, we have an unequal burden of infectious diseases as well. So this heat map just shows the distribution of infectious and parasitic diseases from the World Health Organization. And you can see that in general, the global south bears the brunt of the burden of infection more than the global north. And I'm sure all of you have opinions about the response to COVID-19 and things like the vaccine distribution, and how disproportionately wealthy countries were able to access vaccine in the face of a global pandemic. And I think there are large issues here to do with inequality, to do with wealth disparities, and to do with historical trajectories that make this unequal distribution not just to do with biology and politics and society, but also to do with where we need to go in the future. So we have a global heterogeneous distribution of infectious diseases. You can have a heterogeneous distribution of infection even within the same country with two different kinds of disease, because they're transmitted in different ways. So these heat maps show a cholera outbreak in Sierra Leone on the left and an Ebola outbreak in Sierra Leone on the right, not that far apart in time. And you can see that the prevalence of the burden, so this is the reproduction number, which is just a measure of how much transmission is happening. And you can see with cholera, the outbreak started here on the coast, and this is a waterborne infectious disease, and it sort of spread outwards from there. With Ebola, because it has a different dynamic, because it's a different kind of infection, and it takes 10 days to become infectious, we have this much more distributed pattern. And you can see that from a public health standpoint, if you're the control program that has to respond to these threats, you need to have a different surveillance system, and you have to have a different approach to where you send your resources. Even within cities, you can have very different outcomes and different burdens of risk and heterogeneity depending on where you are. So this is a map of New York City, and it shows the prevalence of COVID-19 infection throughout the city. And what you'll see is that Manhattan, so this is Manhattan, has a very low prevalence compared to the surrounding neighborhoods. And the reason for this is because generally people that live in Manhattan are wealthy. And when the lockdown started, they left Manhattan to go to the countryside or some other place. So Manhattan emptied out, but people in the poorer surrounding areas couldn't leave. And what's more, many of them were essential workers. So they had to commute in to the center of the city and around the city to keep services going. And they bore the brunt of the epidemic. So if you think about where you would send resources during a public health emergency like COVID-19, you really have to understand on a local level what's driving the burden of disease and who really is the population at risk and what they need. So that's what we do. We work on surveillance, basically, trying to understand who's at risk, who needs help, who needs what, and how is that changing over time. So here's just an example. This is actually Cambodia, and it shows the distribution of malaria prevalence. But you can imagine that this could be any infectious disease or an area that's affected by a wildfire or a flood or something like this. And what you know is that some communities are facing particularly high burden. What you need to do is get those populations at risk the things that they need, whether it's shelter, whether it's wash facilities, whether it's food, whether it's medicine, and you have to get that to the population at risk. And the way that we build these maps and understand where the need is most is that we have reports from clinics and hospitals in the case of infectious diseases. For things like hurricanes and floods, we might have satellite information. We might be in communication with regional outposts and things like that. But where the responding agency is going on some information about who needs what and where they are. So one of the issues for an infectious disease outbreak is that we don't just want to know what's happening in a place, but we also want to know how different places are connected. So when I talked about those different kinds of migration and mobility that have increased so much in recent years, that's very important in the context of infectious disease outbreaks, because people moving around a country are what is going to drive transmission and create those hotspots of infection. So this is during the early days of the COVID pandemic. People were ignoring public health advisories and gathering, causing transmission hotspots. And then they would move around and spread disease to other parts of the country through imported infections. And so the question is, how do we learn beyond knowing what each clinic is dealing with in terms of number of infections? How do we know what to expect? Imagine you have a map and you have, a hotspot of infection, but actually that hotspot of infection, all those people have now gone home and they've taken the disease with them. And so we will expect that there will be all kinds of infection in other parts of the country very soon. We want to understand what those travel patterns are. In the context of natural disasters, we want to know where people have been displaced to, so we can make sure that we get the tents to the right place. In the case of a wildfire, we want to know where to evacuate people and which hospitals those evacuees will need to go to, and so on. So even though infectious diseases are different from natural disasters, many times the crux of the resource allocation problem is, where is everybody and where are they going? It boils down to these simple things. The problem is, until recently, we didn't have a lot of good data to tell us that, especially not in real time, and especially not with rapid turnaround that we would need during an emergency situation. So on the left, these are the kind of traditional types of information that we have available to us about human travel. And on the right, we have kind of the modern landscape or ecosystem for thinking about data from human mobility and migration. On the x-axis, you have the spatial scale from neighborhood to regional up to international. And on the y-axis, we have the temporal scale. So is this hourly, daily, seasonal, and so on. And in the past, the types of data we had available to us were really a travel history survey. So you go and ask people where they've been. And that's still a huge source of information for things like malaria. Then we have cross-border surveys, which of course isn't useful within a country, but it's sometimes useful for understanding flows between countries, depending on how well reported that survey is. And then we have the census. The problem with the census data, although it gives you a lot of good demographic detail, it doesn't give you real-time information, and it doesn't give you rapid displacement that you might get in the context of a disaster or during an epidemic. So the timescale is not so useful. On the right here, we have the modern landscape. So now that everybody has mobile phones, and I'm sure you are all aware of the sort of increased use and penetration of mobile phones around the world, we now have massively expanded data sets that tell us about where everybody is and where they're going. So I've sort of drawn these are from a paper, but they span different spatial scales. They're all slightly different. We have satellite nightlight data that can tell you about where people are settling and making fires and so on. And then we have extremely granular, detailed data from Google Maps and so on. You have these anonymized mobile phone records, and I'm going to talk about these. I've been working on these types of new data sets for some time, trying to figure out how we can use them for public health purposes. This is just to say, often people say, well, not everybody has a phone, and so is it biased? Yes, this data can be biased. For example, children, older people, very poor areas, rural areas that aren't highly connected. So it's not appropriate for everywhere, but there has been remarkable uptake of mobile phones in most countries. And I think now it's pretty good in the context of cities, especially. We can talk about that in a sec. So there are two main sources of information or types of mobility data from mobile phones. The first is mobile operator data. So this is, for example, if you have, whoever your provider is, they collect this data routinely, and it just associates your phone call or your text message with a cell tower. So the cell tower that call is routed through is logged by the company, and they use it for things like business analytics and so on. But if you know the latitude and longitude of that cell tower, then you have an approximate location for the person at that time. So you can build up a kind of a map of the towers that a particular person was associated with. And this is sometimes used for things like legal cases, when people say they were in place A and they were actually in place B. In most countries, mobile operators are not allowed to share this. So they have to aggregate it to the point where you can never recapture the individual trace. On the right, we have an example of a GPS trace from social media. So maybe you've got Google Maps, maybe you've got Facebook, maybe you're using some other ad generating app or something like that. And then you have a much more highly granulated data set where you know exactly, you have a GPS trace. And again, these can be aggregated up to an anonymous level, but these data sets are quite new, and so there's still some issues to do with privacy. And I just want to highlight the fact that we've been trying for many years to work on regulatory frameworks for the safe, fair, and equitable use of this kind of data for public health and social good purposes. I think there is some issue with companies starting to sell this kind of information that is very problematic. And in fact, last year, I co-hosted a National Academies working group to try to understand the governance frameworks for this kind of data. It's very helpful, but it really needs to be used responsibly and ethically with really robust algorithms for making sure that people, vulnerable people especially, are not being exploited. So what can we do with this data? So here's an example of a paper that we did a few years ago where we looked at different kinds of information about mobility after Hurricane Maria in Puerto Rico. And the question that the Puerto Rican government and the US government wanted to know was how many people left the island after the hurricane. So you can see here, this red dotted line, that's the landfall of Hurricane Maria. And we have 4 types of data. We have census data that's collected only twice, once before and once after, and it shows a sort of straight line decrease in population. We have flight data from airplanes, and that shows this pattern here. We have CDR, so that's these call detail records from mobile operators, and this is aggregated across different mobile operators combined. You can see a little gap here. Many operators lost power during that time. You can see a sort of daily oscillation of people. And then finally, we have data from Facebook. So these are people who are using Facebook on their phone and they have location on. And you can see a very rapid decline of the Facebook users. So the point I want to make here is that each of these kinds of data can add information to your policy, right? They tell you slightly different things. They occur on slightly different timescales, and they have different biases associated with them. They're all biased, but they will have different biases associated with them. And so when you put them together, you can see that probably a lot more people left the island than we would have thought, and maybe there was some rebound afterwards. And that matches with what we know about how people behave during and after natural disasters. And we can start to calibrate some of our models and conduct surveys designed around a better, more granular set of data points in using these different data sets. So we've worked a lot to try to see how to combine this with infectious disease or epidemic data to help control programs with surveillance and response. This is work done with IEDCR and Grameenphone in Bangladesh, and this was led by Aisha Mahmood, who was my postdoc at the time. And what we're looking at on the left is a heat map showing travel in and out of Dhaka. So Dhaka, I saw many of you from Bangladesh, welcome. Here in the middle is Dhaka. And what you're looking at is travel during the Eid holiday. So at the beginning of Eid, everybody leaves to go to the countryside to visit family and so on. And then at the end of the holiday, they come back into the city center. So this is now real-time information about people leaving and coming back. And when you look at this data over time, so here what we're looking at the proportion of cell phone people with subscriptions to Grameenphone leaving Dhaka over time. And what you can see is this weekly oscillation. So weekends, people leave and then they come back to the city and so on. This vertical line here is Eid. So you can see a lot of people then leave the city and then they come back. And here, this heat map shows distance. It's the districts ranked by distance from Dhaka. So Dhaka's at the top, and then it's how far away the other districts are down here. And all this is to say that even places that are not usually traveled to from Dhaka that much, the dark blue lines and the ones very far away, during Eid, we get really mixing of the country because people are going away to spend time with family and celebrate the holiday. So at this time, there was an Eid holiday right at the time of a chikungunya outbreak. And so we wanted to ask the question, could we use this information to better target surveillance? Outside Dhaka, there's not so much surveillance for arboviruses like chikungunya and dengue. And so we wanted to see if we could help target the resources they did have to identify places that might be at high risk. So here is data from the city, from Dhaka, of the cases. These are estimated from a survey. We had various data sources on this. And you can see here's a map showing the estimated cases per household. So again, a heterogeneous distribution within the city of which households were affected and which areas were affected. And so what we were able to do is to build a mathematical model of the epidemic. And you can see the fit of the model to the data here on the top right. This is just a schematic of the model, don't worry about that. And then with that model in mind, we estimated how many people we thought might travel to different parts of the country from the areas that had a lot of chikungunya. So again, this is not following individual people. This is nothing to do with individual patients. It's nothing like that. We're just saying we know that approximately this fraction of the population is moving from this neighborhood to different parts of the country. If a quarter of them are infected, how many do we think are going to be going to different parts of the country? So again, completely anonymous. We're not working with individual patient data or individual mobility data. But from that, we're able to say, well, we think that we're going to expect cases sooner than you might think in some parts of the country and less than you might think elsewhere because of these patterns of mobility and migration. And so then surveillance could be enhanced in the places where we think, oh, I'm just going to plug in my laptop. Hold on. This would be very bad if this let me cut out. Okay. Right. Compared to the places where we don't think it'll happen so quickly. We've used a similar type of approach in this is in Sierra Leone again, looking at the lockdowns in response to Ebola. And this was work led by Corey Peak in my group. And this was just using a very simple anomaly detection algorithm to measure very short lockdowns and see if they were being adhered to by the local population. And what you can see is that it's very easy to use a very simple algorithm to detect anomalies and show where the lockdown is working. And then you can see a rebound when the lockdown is lifted. Now, of course, the biggest lockdown ever happened in 2020, and it happened all over the world. These graphs just show the timing of different lockdowns in all different parts of the world. I'm sure all of you experienced some kind of lockdown wherever you are. It was really unprecedented. So this is an example of the travel patterns from mobile phones measured before and after the lockdown. 4 weeks before March 16th and 4 weeks after March 16th. And you can see dramatic changes in travel. And that really impacts what we expect in terms of the epidemic spread. The other thing that we saw a lot was that populations moved from the urban centers out to the countryside. And this happened everywhere in the US. Here I'm showing France, India, and Spain. And what we're looking at is the yellow bar, the yellow line is basically urban places. The bluer the line, the more rural it is. And the y-axis shows the change in population density. So when the lockdown happened, the yellow places, the urban places, lost people. People left the city. And in the rural places, they gained people as people moved out to the countryside. This happened everywhere. And in many cases, it probably spread the virus faster than would have otherwise happened. Again, this is Bangladesh. And we see the same thing. So the high nightlight categories is just urban centers, so Dhaka, and maybe in Chittagong as well. But down, you see a drop-off of people in those high density populated places and an increase in rural populations. Interesting here, we have an overlap between the COVID-19 pandemic and the Cyclone Amphan. I don't know if those of you who were there remember, there was a cyclone right in the middle of 2020, which again, complicated response to both types of disaster. We have these complex overlapping public health emergencies now. Okay, so I want to sort of start ending my talk by discussing how academia trickles into decision-making. I think COVID-19 really exposed some of the gaps between science and scientific translation in the context of policy. All of the work that I've showed you thus far, most of it has been academic. So it ends up in a paper, in a journal, and we prove that you are able to do these things. We show that it's possible. And then the question is, who is taking these methods and actually making them work in the context of real-time public health emergencies? This is a major challenge. And at the moment, there is a massive split between academic science and the reality of public health emergency response on the ground. In recognition of that, we started this platform, Crisis Ready. Sachit Balsari, who is a Harvard Medical School professor, and Andrew Schroeder, who works for Direct Relief, which is a humanitarian aid organization, and Nishant Kishore, who at the time was my grad student. So we set up this network to really try and move this conversation from just showing that methods can work into a much more tangible translational readiness piece for public health emergencies, where we collaborate with responders to make this stuff actually useful. It's very hard at the moment. I think there's large gaps infrastructurally and institutionally. And so I think this is going to be a major defining challenge for public health emergency science moving forward. The trouble is that academic science tends to be highly technical, and it requires a lot of analytical capacity. So if we've got this pretend y-axis of how much technical analytic capacity you need here on the y. But real decision-making has to be local, it has to be specific, and it has to happen fast during an emergency, right? So the question is, how do we create an infrastructure that allows rapid translation of highly technical methods into real-time decision-making that's actually useful? I think this is a big problem. During COVID-19, the parts of this challenge that we were trying to address were like, okay, we know how to process mobility data. We've been doing this a long time. We know it's useful. We know that policymakers want to make decisions about non-pharmaceutical interventions and lockdowns, but they don't understand how to do this, and they don't have the technical capacity to do so. They're just being bombarded by stuff on the internet that isn't actually at the right scale and doesn't address the specific problem that they need to answer in their local district. So we created really what it was a network of people, and the people were in situ, and the people needed to be trained how to use these mobility data effectively. The data sharing agreements had to be in place, and we provided code and access and everything. And then every day we provided reports to policymakers to help them make sense of what was happening in their communities and what they needed to do for the rollout of their response. So for example, every day we'd say, people have started moving out of this place. If you're going to have a mobile clinic, you should put it in that place. Very concrete, simple things. And we've since expanded this kind of way of doing work, I guess, into a whole network of people around the world who are involved in translating some of these methods and data into actual decisions in the context of different disasters. You're welcome to have a look on the website and see what we've been up to. The key to making this work, and I think this is going to be key to all public health emergency response for the 21st century, is that you have to have local knowledge and expertise that drives the methods development. So academics need iterative engagement with partners on the ground so that the products are useful. This is an example from a wildfire dashboard that we made in collaboration with the California Department of Health, where we worked with them over months to figure out exactly what they needed to know. They needed to get fire trucks somewhere. They needed to make sure the hospitals receiving patients were ready. We had to work with them very closely so that we could make sure that the tool that we were producing was useful. It's very easy to want to make a very clever thing and make, beautiful pictures, but unless it's useful to the first responder, then it's just academic and it's not going to be helpful. Here's a couple of more examples. We've done it. We've responded to the Ukraine crisis. We've responded to multiple natural disasters, the earthquake in Turkey affecting Turkey and Syria, of course. We worked with partners there in the UN, the World Food Programme, the Red Cross, and so on. Most recently, there was a cyclone that affected India and Pakistan. And so what we produce for them are reports that show where people have moved away from and where people are moving into. So essentially population displacement maps. Here, you can see the blue dots are where people have left, the yellow and the red dots are receiving. And then here in the bottom right, we've also got information about the earthquake intensity. Okay, so the landscape of this type of work is changing quickly, and I'll just end on this. It used to be that we required all of this, national regulations, data use agreement, institutional review boards, ethics. This was quite right. We need to make sure that we are doing everything safely. What's happened during the pandemic and since is that we've started to get data brokers who are not necessarily conforming to the strictest of ethics. We've got law enforcement starting to use this data as well. Sometimes this is for-profit model, which I think is going to be a complex political situation. I'm happy to talk more about this, but this whole field of using mobile phone data in the sort of public health and public policy realm is really changing rapidly. And so I think we'll see some changes, a lot of changes in the next few years in this space. So last, I want to just give you a question. So what do you think would happen if another pandemic hit? My personal sense is that we wouldn't be so much better off than we were in 2020. We need to have much more locally driven decision-making. We need to start building a workforce globally who are technical and very much embedded in a location. And so maybe that's all of you. What institutional and governance structures can we start putting in place to facilitate rapid decision-making to prepare for the next crisis? And then the biggest lesson, in my opinion, of COVID-19 has been that without local knowledge and local trust in government, public health doesn't work. And so we really need to start understanding the social fabric and not being so focused on technical scientific findings and starting to really value and understand local knowledge and build trust. And then one last thing, this is something I care about very much. We need to have more women and a more diverse workforce in global health. So only in 2019 did the World Health start disaggregating global health statistics by sex, so that we can start to understand the impact of different policies on women. We're just starting to understand that we need a diverse workforce. We need voices from the Global South. We need a lot of Global South collaboration and networks, and we have to start investing in that. And in general, global health is delivered by women and led by men. And I see this everywhere. I see it in my own institution. And I hope that we can start making a difference and pushing for more women in leadership in global health. And so maybe some of you can be those future leaders. Thank you. So I'm really happy to take, there's a lot of hands, a lot of questions. Maybe you can help me navigate this.
Sure, yeah. I did want to take one quick moment to go ahead and share the attendance link for this session. You can see right there in the chat. You can log into your Aspire account, and once you're logged in, you can click this first link here in order to access your attendance form. Again, you must be logged into your Aspire account before accessing the attendance form. You can also take this link and hold it off to the side in case you're not able to move away from Zoom right away. Just go ahead and save that link and it'll be open until the end of the day today. All right. So now to ask some questions, I'm gonna call.
I can read off the top of the Q&A.
Sure.
Or how do you want to do it?
So what we'll do, I'll take some questions from folks with their hand raised, and then we'll maybe do one or two questions. And then if you see a question in the Q&A, you can go ahead and answer that.
Okay.
And then we'll go back and forth with that. All right. So first up, Emmanuel Sanigo. Sorry if I mispronounced your name, but if you'd like to unmute and ask your question.
Okay, my name is Emmanuel. I'm from Kenya. So my question is that as much as we are checking on the consequences of infectious diseases that are short-term, there are other long-term consequences, such as the conditions that come up, like chronic conditions, disability, mental health. How can the community or the worldwide, like the world, try to cope with this, like to help these people who are like facing these challenges that come up with the chronic condition, with everything that comes up?
Yes, that's a great question. So, epidemics tend to be fast, relatively, although things like endemic diseases like TB and malaria, of course, are constant causing problems. But yeah, you're right. So I think the aging of our populations, as well as some of the lifestyle changes associated with a move from a rural to an urban situation, so the rise of obesity and things like this, have major consequences for non-communicable disease burden. And so I think what we're going to see is these entangling of these different public health disasters. So just one concrete example, in Puerto Rico, when Hurricane Maria hit, some people died because they drowned, but most people died because they were elderly, they required electricity-dependent medical devices, they needed insulin, they were on dialysis, they had these chronic conditions that you mentioned, and they, without access, because the roads were washed out and they couldn't get to the hospital, they died from those things. So I think when we start doing a better job accounting for things like cause of death in relation to these acute disasters, we'll start to see how the burden of chronic disease is going to impact vulnerable populations. So for example, at the moment, it's very hard to attribute cause of death to a hurricane if what actually killed you was 2 months later you didn't have dialysis, right? That would go on a death certificate as your dialysis didn't work. But in fact, it was the hurricane, but it killed you because of your lack of access to care. And so I think we need a reformulation where we start to think holistically about health, not just infectious, but as these tangled up and related threats. So the natural disasters are going to inevitably affect people that have chronic conditions worse, and we need to understand those relationships better. So I think it's a very good point, and certainly non-communicable conditions are going to increasingly play a huge role in how we define vulnerability, as well as what we need in response, right? It's a good point.
Thank you, Emmanuel, so much for your question. I see another hand raised by Jennifer Raymond. Jennifer, I'm going to ask you to unmute and you can go ahead and ask your question. Jennifer, are you there? Okay, so I don't hear anything from Jennifer. We'll move forward to someone else. Jennifer, if you have your question, you can type it in the chat. I see Caroline Akinyi. Caroline, if you'd like to go ahead and unmute.
Good evening, everyone. I'm Carolina Kinyopio from Kenya. Thank you so much, Caroline, for that wonderful presentation. It was a good presentation. I only have one question. So my question goes, what research and innovations are being pursued to enhance preparedness and response for the public health emergencies?
What research and innovations did you say?
Yeah.
Well, so there's a lot of research. I think, we've been working on one kind of data from mobile phones, but there's been a huge amount of work on how you use phones for communication with vulnerable groups. There's a lot of interesting work on genomics, so using pathogen genomes to track, for example, potential outbreak-causing pathogens spreading around the world. I think and also satellite imagery there's a quickly changing landscape of research and innovation around satellites and the use of things like drones. So drones are very useful in the context of reaching populations that have been stranded or, in areas that are difficult to get to. So I think there's a lot of technology being explored right now that can help. What I would like to see more of is a focus on some of the social and inequality, sort of the more social and political aspects of public health disasters. I think that we really need to start to invest in research there. And I mean, I hope that in the wake of the public health emergency that was COVID-19, we will see more of that, but people tend to be obsessed with technology. And so I don't know exactly where the funding will go, but certainly there's a lot of interesting tech and research.
Thank you so much for your question, Caroline. Oh, sorry, wrong name. But yes, if you'd like, we can take a question from the Q&A.
Sure.
I can read one out, or if you want to pick one and go ahead and answer it, that works too.
Let me pick one out. So this is from Ian Prosper Takomwa. How does international collaboration and cooperation factor into the response to global health emergencies? I think this is a very interesting question, and one where I think we saw this break down during COVID-19. Right now, when a natural disaster or a public health emergency happens and it's localized, what happens is disaster response agencies kind of amass around the site. So we saw that, all the way in Haiti. We've seen that in Ebola. We've seen that in many places. And it's a little bit chaotic. I think that international collaboration is imbued with the same political and power and wealth inequalities as any other process that we have that's driven by humans in the world right now. And I think there needs to be a real reckoning around who has the power, who has the right to control some of the decisions, and a better framework for cooperation. And like I said at the start, I think the failure of the vaccine distribution with COVID-19 to reach vulnerable populations in the global south really highlights some of the big problems. And I'm hopeful that in the future, we'll have vaccine manufacturing capabilities on the African continent, for example. We'll have much more local capacity that will be able to bypass some of these historical inequalities and existing problems. International collaboration has to be at the heart of some of this stuff, especially infectious diseases, because we're all connected. right? So an epidemic in one place is going to spread everywhere else. And so we have to start thinking about this with national borders, and we have to start thinking about this as regional cooperatives and as a global species level cooperative. I don't know how we politically get that to happen, but I think it's going to be essential, and it's probably one of the biggest barriers to making sure that we are prepared for the next big crisis of the 21st century. So that's a good question.
Thank you so much, Ian, for your question. We can do one more question from the Q&A, and then we'll do a bit of a lightning round for the raised hands.
Maybe I'll answer. Should I just choose one?
Yeah, sure. You can choose one more.
Sanskriti Sharma has asked, what can be done at the individual level to prevent infectious diseases among the community to which it belongs? So this, I want to just tell one story. So we have, Sajid Balsari is leading a project where we're starting to work with the Self-Employed Women's Association in India, which is a large organization of women in the informal sector. And they are sort of a cooperative, and they have millions of members. And during COVID-19, they organized and got together, and they switched industries to start sewing masks. They took on leadership in their communities to prevent transmission, made modifications, made sure that infrastructure like wells were working, and so on. And I actually think that the community level is where we're going to see the best protection against pandemics in the future. It's in bringing some of this technology that we develop in the global north or wherever to the community level, and making sure it's useful for the purposes of individuals and communities who can work together to prevent these outbreaks. All outbreaks start locally, right? They all start on a small scale, and it's only when they get out of hand that they become a global problem. But if we can protect communities and empower them to make differences themselves and collect data themselves to advocate for interventions and various things, then we really have a chance, I think, to protect the whole global population for against emerging infectious pandemics. So, simple things. Dengue outbreaks can be stopped locally if you just make sure that there isn't standing water for the mosquitoes to breed in, right? You can take steps to prevent the transmission of airborne viruses and do hand hygiene and all these things. So I really think that the community level is where it's at in terms of trying to design tech and design analytics that will help empower individuals and communities to protect themselves and their neighbors.
Thank you again for your question. So now we'll do a little bit of a lightning round of questions. I'll call on 3 people to ask 1 question each. So I'll unmute them, they'll ask their question. I'll unmute the second person, they'll ask their question. I'll unmute the third person, they'll ask their question, and then you can take your time and answer all 3. Okay. So the first person I'm going to call on that has their hand raised is Amina Baror. Again, sorry if I mispronounce your name, but Amina, if you wanted to go ahead and unmute, you can ask your question.
Hello, Caroline. First of all, thank you so much for the fruitful presentation. It was so enlightening and covered the subject from so many perspectives. My question would be what we could do to actually have this the gap between the academic and the policy makers. What we could do to fix it.
That's a great question, and it's something that that I and many others are trying to understand how to do a better job. Sometimes it has to be institutional. So, for example, in some countries like Norway and in England, they have institutions that are kind of partway between academia and government. So they're like a public health research institute that is partly funded to do research and partly funded to help the government with specific public health tasks. And those types of institutions, I think, are going to gain traction and funding over the coming years. I know people like the Gates Foundation have been trying to understand how to build these in the context of Africa, and with the Africa CDC and so on. They're trying to figure out an institutional way to bridge that gap, because the gap's only going to grow, right? We're going to get more and more and more technical solutions, and without, lockstep with deployment, it's not going to reach people and communities. So you could have an institutional solution. You'll need significant funding for that, but I think that a lot of people are thinking along those lines. You could also think about ways that governments can be more creative about their teams and education for people in government. So at the moment, many people in surveillance need only a small technical training, and maybe that's okay, but you also need at least one person that knows how to, is embedded in academia for a few months of the year or something like that. But all of this is going to take significant investment and a reevaluation of how we structure our whole scientific approach to public health. So I think it will happen at different times in different places. And I'm hoping that there will be sort of a large amount of investment to try and make it happen institutionally, because I think that's the most promising way.
Thank you again for your question. I'm going to take the two questions at once here. So again, I'll ask one person, unmute them. Well, sorry, I'll ask one person, unmute them, they ask their question, I'll mute them. I'll ask another person, unmute them, they ask their question, and then you can answer the two of those.
Oh, okay.
Yep. So this person I'm going to unmute is Tejas Tekawade. Sorry if I mispronounce your name, but you can go ahead and unmute and ask your question. All right, Tejas, are you there? It looks like he's not there. This next person, Mohammed Abdullah, if you would like to go ahead and unmute your microphone, you can go ahead and ask your question.
Hello, everybody. Well, I'm so happy, and I want to say thanks to the madam for the beautiful presentation. There's a lot of things that are very important. Well, I am from Liberia. Liberia is a country that has been faced with a lot of health challenges. In 2014, we were struck by the Ebola crisis and later the pandemic COVID-19. So, well, there are a lot of issues our country has been faced with, and I have been thinking as the executive director of the Virtual Health Network, how can Liberia as a country that has low-skilled personnel in the health sector use an innovative approach to identify outbreaks before they become a problem?
Mohammed, it's a little hard to hear. Would you mind also typing your question in the Q&A, just so we can also reference that as well? It's a little hard to hear.
Can I get something? Hello?
I'm sorry. Yes, could you ask your question in the chat? We can't hear you too well. I'm going to mute you, but ask your question in the chat and we'll read it out loud. Thanks so much. And I'll try with another person, Namzul. Namzul Alam Joni, you can go ahead and unmute and ask your question. All right, folks, if you do have your hand raised, please make sure you have your question ready. And Namzul, you can go ahead and ask your question.
Yeah, I saw many questions against in Bangladesh. Many research are in Bangladesh against pandemic. So I asked a question to Professor that in pandemic of Bangladesh, so there are concern in public health, and also government try to cover up the consciousness of public health. So in my sense, and how can we overcome, and also how can we spend our time during the pandemic, or how can we improve our public health? That's my question.
Caroline, were you able to hear that?
No, did you understand?
No, I also couldn't understand.
Maybe
Naz-
in the chat or.
Yeah, Nazmul, could you also put your question in the chat? It was also very hard to hear. We'll read it out loud. In the meantime, yeah, we can take a question from the chat if you see one that sticks out at you.
Okay, somebody was asking about how we use the data and make sure that it's private. So this is a major issue. What you have to do is, or what we've done is, we work with the mobile operator and then they aggregate the data. So they aggregate it spatially, they aggregate it in time. And so you'll have, for example, 400 people or 4,000 people. We make sure that we don't use very small numbers, because then we run into problems with identifiability. Like 5,000 people moved from this place to that place within 24 hours. So we make sure it's aggregated before it even leaves the firewall of the operator system. And we work very closely with them to do that. For Facebook has spent years developing what's called disaster maps, where they also aggregate data and they make sure that it's anonymized before we ever see it. So we never have access to personal information or anything like that. Somebody said, are there any limitation discovered to the use of mobility data? Yes, absolutely. First of all, we don't have any individual data or demographic information, so we only know raw numbers. So we don't know the demographics of those people. We know we're missing children and elderly. And then in some places, there aren't that many cell towers, and so the resolution of the data is quite low. So it's not useful for everything. It's very good in highly populated areas, and it's good for mass displacements.
We'll take a question from someone with their hand raised. Again, if you have your hand raised, please make sure you have your question ready. We'll be taking a question from Philister Kalume. Philister, if you'd like to unmute, you can go ahead and ask your question. Philister, are you there? All right, we'll be moving on to someone else. Shah Khalid, if you'd like to unmute, you can go ahead and ask your question. Okay. All right, again, everyone, if you do have your hand raised, again, please make sure that you have a question ready. Let's see, I see a question from Randy Praise. Randy, if you'd like to unmute your microphone, you can go ahead and ask your question.
Okay, thank you so much. My name is Randy Praise. I'm from Cameroon, and I want to ask on the aspect, I think someone already mentioned this, the aspect of mental health disorders in the 21st century, because when we talk about public health emergencies and as youths growing up to effect positive change, like what is the aspect of mental health disorders, let's say drug addiction, substance abuse, depression, anxiety? How did it come about, and how can you track that at an epidemiological standpoint? And what is the population at risk? And from all of this, what can we do to respond to this public health emergency?
That is a fantastic question. And what I would say is that it is really early days for people to really understand this. I think at the moment, we do not quantify the mental health impacts of public health emergencies, or just public health, the mental health burden in general right now. So it's poorly classified, especially in vulnerable communities. And so what that means is, without good baselines, it makes it hard to see changes, which makes it hard to see which policies are working as well. So I think this is a big gap, and it needs to start to be incorporated into a holistic assessment of impacts of these kinds of public health emergencies. I would say that, after Hurricane Maria in Puerto Rico, we did a study again on mortality, and what we saw was that our partners are psychologists, and they saw an enormous rise in suicide after after the hurricane. And we know that mental health is massively impacted by some of these disasters. People lose their homes, people lose their livelihoods, and their loved ones. And so I think this is a really critical need in research and in funding. At the moment, it's very poorly quantified. And so the first thing that we need to do is to start measuring it. So that could be done with systematic surveys. It could be done with better linkages between clinical psychology data on an epidemiological level with the climate and health data for natural disasters or in the context of infectious diseases. So some of it is really about bringing data from siloed parts of ministries of health together to try and understand patterns of what's happening. And then we can think about ways of addressing it. But this is a really good issue, and I'm glad you raised it because I think it's a really big need right now. There's not a lot of literature on this, and I don't think there's enough being done in terms of quantification and policy research.
Wonderful. Thank you again. I see a question, I see a hand raised. Maria Paula Torres, if you'd like to unmute, you can go ahead and ask your question.
Hello.
Hi, I'm Maria Paula Torres. I'm from Colombia. And all these mechanisms, these skills require management support from the government. I live in a country where the government has historically been inefficient. From the private sector, what can be done and what examples are there of people who have done something?
This is a good point. So there are a lot of people that say the private sector must respond to public health needs because governments are inefficient and so on. I think that the problem is that in the private sector, the incentives inevitably are not always aligned with social good. So there are examples of companies who do a great job with technology transfer and who step in and with diagnostics, for example, or with rapid diagnostic tests during COVID-19. We've seen the rise of companies like Ginkgo Bioworks, who have started to do wastewater surveillance from airplanes and so on. Usually governments end up having to pay for that because public health can end up being problematic if it's privatized, just simply because the incentives are different in business. I think, honestly, though, this isn't going to be an either or. I think that we have to start building sensible public-private partnerships and working on financial mechanisms that will enable companies to innovate and take risks on some of the technology. So, for example, climate insurance policies, things like that, right? So modifications to insurance is going to be an important way that we start to prepare communities and countries. Some of the technology developments and R&D for drug development and so on needs to be done with very clear public-private frameworks that will make sure that the products get to the people that need them at the right time. It's a very complex landscape, and I'm not going to pretend to be an expert in how public-private partnerships should work, but I think it has to be both. So yes, that's what I would say.
Thank you again. We'll try one last time with the lightning round. Hopefully this works this time. So again, folks, if you do have your hand raised, please make sure that you have your question ready and you are ready to unmute when we call on you. Right. So this first person I see here is Saida Dua. Again, Saida, if you'd like to unmute, you can go ahead and ask your question.
Hi, I'm from Pakistan, and I have two questions basically. What are the most effective strategies for communicating public health message during an emergency to ensure the widespread adoption and compliance? And the second one is, how can we ensure that the marginalized communities have equal access to healthcare during public health emergencies?
Thank you. Next, I will be unmuting Burfin Imra. So Burfin, if you'd like to unmute, you can go ahead and ask your question.
Thank you. I'd like to ask the question where you're saying that there should be a centralized or localized decision for an emergency health situation, how can we make sure that this decision maker is not from a corrupted background or person? And are they supposed to be connected to the government or some kind of independent institution? Thank you.
Thank you. And the last person is Regard Alshi. Sorry again if I mispronounce your name, but you can go ahead and unmute and ask your question.
No worries. Hi, thank you. My question would be is there any other way in order to get results than collecting data or analyzing data, especially in countries? I originally come from Syria, and for us it was not accessible. It was very, very hard to get into data or to know like how can we reach people, like, or how can we know how many people are like affected from COVID, for example? And is there a better way to actually get results? Thank you so much.
Thank you all.
Okay, I think I'm going to try and remember. Okay, I'll take them backwards, and maybe I'll ask the first person to just repeat their first question at the end. So without good data, it's very hard. And I think that if we focus our investments for research on technology anywhere, it's for this particular problem, which is how do we get data from places which are very hard to reach, or there's some problem with data collection and reporting. This is something I work a lot with in remote populations. I would say that there's a flip, there is sort of a double-edged sword here. So remote sensing is getting better and better. So we can see from satellites, we can use drones, we can use mobile phones. This is kind of passive observation of data that we can do without having to go to the place. On the other hand, first of all, in places with vulnerable communities, that intelligence for public health can also be used for things that aren't public health. And so that has to be very carefully regulated to make sure that vulnerable populations are protected and not exploited. I think, again, data collection in places that are affected by conflict, it's a huge, huge challenge. My hope is that things like mobile phones and like local wireless networks that are small and cheap and mobile, my hope is that those are going to start to improve the data infrastructure in places like that, and we'll be able to get better data. But without good data, you're flying blind. And I would add that no amount of analytics and modeling can make up for poor epidemiological data. We really need that information from the field. As far as local decision making, how do we prevent it from being corrupt? You know, that is a hard problem also. Every place is going to have its own unique ingredients for getting this right. And I think it's going to be difficult to not have corrupt leaders at every locality. But I do think more transparency and better data flow is going to make it easier to identify where reporting isn't working, for example. The first question, I think, was about public health messaging and how we get how we make sure that we're reaching people with our public health messaging. I think this is really the key here is local as well. So when historically, when governments switch to having communities choose a community health worker, where they decide on who it's going to be and they trust that person, instantly you have a much better uptake of everything from childhood vaccines, safer delivery. And so again, I think the key there is local trust, and that will be different in every different place, how those types of trusted individual are chosen and how we make sure that they are educated and know how to communicate. But in general, it has to start with somebody in the community that people trust, especially in places where people don't trust their government. And I would say that applies here in the US just as much as anywhere else. And so that's the biggest thing there. I think that's most of the questions.
I think there was one more. I believe it was Saida's question. Saida, I'm going to unmute you again. Would you please ask your question a second time?
My second question was, how can we ensure that marginalized communities have equal access to healthcare during public health emergencies? And another question I want to ask, what role will artificial intelligence and machine learning play in predicting and mitigating the impact of future public health emergencies? Thank you.
Thank you.
Okay, so I think the key to protecting vulnerable communities is to understanding where they are, who they are, and what they need. So that is a preparedness thing. We need to have a better definition of vulnerability. We need to understand who in our community is most vulnerable. We need to understand what their needs might be for different possible outcomes, so that we're ready to provide them with what they need when it happens. So again, I think a lot of this is in the preparedness side. At the moment in the US, for example, our hospital system doesn't automatically know that all the diabetes patients are in one neighborhood. They don't have a sort of systematic map of vulnerability where they know who needs what and where they are. And we're trying to help with that. But I think that's where it starts. It has to start with community level mapping exercise of that can happen even on a very local scale with just people in the neighborhood knowing who needs what. So if you know that you're in a cyclone prone area, hurricane prone area, you know, and your mayor or your whatever administrative level leader should know in advance who's on oxygen, who needs refrigerated medicine. You know, community level preparedness is key. And that's where it starts. And it's really gathering that data up front and being prepared so that when something happens, it's easy to know what's needed for distribution. In terms of AI, I think AI is used as a term far too much. I think people throw it around without knowing what it means. Often it means regression. It would mean simple regression analysis, but they're calling it AI because it sounds fancier. It is a very powerful tool. I don't know if many of you have experimented with ChatGPT. It's very helpful for some things. And I think that it will also do a lot for, you know, synthesizing data, synthesizing knowledge, translation into local languages. It will make it play a huge role. In terms of predicting what's going to be needed, that I think depends on the nature of the disaster. You know, one of the things about epidemics that make them unique, if you predict a hurricane and you say it's going to rain, and then the community all carries umbrellas, that doesn't change the fact that it's still going to rain. If you say there's going to be a measles outbreak and then everybody stays home, there won't be a measles outbreak because it's a socially driven disaster. And so in that case, your prediction is wrong and people stop trusting the prediction, right? So I think these disasters are different. For infectious diseases, prediction is always going to be very challenging. And I don't think AI is going to get around the need for good data, which goes back to the other answer. Without epidemiological data, your models are all rubbish. So, you know, they're not particularly helpful. And so again, I think it will transform things in some ways, and many of them we won't be able to predict right now. But I don't see a way that we are going to get around good community healthcare trust and basic data collection. And again, I would say actually in our world now, if you think about the internet and how much data there is everywhere, there's this idea that this was going to bring people closer together because we'd be able to share so much and have the same information. But what it's done is actually drive people apart, because now there's so much data that people don't know who to trust, and there's misinformation everywhere, and politics has got into all of these conversations. So I actually think that in the future, we will be relying more and more on personal interactions and trust in a person who's standing in front of us. Which is maybe a controversial view, but I really believe that.
Thank you so much. All right, so I do see that we are almost out of time. Thank you so much, Dr. Buckee, for joining us and giving this seminar here today. It really seems like this was very relevant for a lot of our students, and I'm glad that a lot of our students did have a lot of really, really in-depth questions to ask.
Yeah, thank you so much. Can I just say, so I work in Guyana, I work in Colombia and India and Bangladesh. If any Aspire students are interested in hanging out when we're there, that would be wonderful.
It's actually not far from, my family's in Trinidad, so not very far from me at all either. So thank you, everyone. I do want to just share one last time the attendance form in the chat. Again, make sure you log into your Aspire account first before accessing that attendance form. The form will be open until the end of the day today. So that's about 5 p.m. Eastern Standard Time. Again, please make sure you fill out that attendance form to make sure that you get credit for attending this session. Thank you again, Dr. Buckee, for joining us here today. And we hope to have another seminar from you very, very soon.
It's my pleasure. Thank you all for your time.